Thank you all for joining. It's fantastic to have you for today's final session in the Improvement and Innovation Showcase series, highlighting digital and data-based innovations. My name is Annie Simpson, and I'm the Innovation Project Officer here at the Commission on Excellence and Innovation in Health. We would like to acknowledge that the lands in which I'm joining from today is the traditional lands for the Kaurna people, and I pay my respects to their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today, wanting to also pay my respects and acknowledge the lands in which you may be attending from today also. Before we start, a little housekeeping. This session has been preset to keep your mics on mute and the video feed turned off by default. However, this will be enabled during Q&A time after the presentation. Only the presentations will be recorded and published on the CEIH website, and the recording will be stopped for question time. For Q&A, please use your mics or chat function to ask your questions, and please feel free to turn on your cameras as well. And finally, once the Q&A is finished, there will be a survey that pops up on the screen. It would be fantastic if you could just take a small moment to fill out a couple of questions for us. For those of you who are unfamiliar with the Commission on Excellence and Innovation in Health, or the CEIH for short, we're the lead agency for innovation in healthcare in South Australia, and our goal is to bring consumers, clinicians, and other collaborators together to turn ideas into better healthcare. Our vision is together, creating health and prosperity for all. We are all about bringing people together and connecting the dots, one way being through the showcase by really supporting the sector to come together to highlight and inspire imagination of new ideas for better healthcare. So what if the big idea was connecting all the small ideas? This is the essence of why we host the Improvement and Innovation Showcase, helping to connect people across our sector, both within South Australia and in some cases beyond. It's all about sharing ideas, improvements, and innovations. During Showcase series, sessions are approximately 40 minutes and available online at any time. It's also about bringing healthcare teams together and providing a space to really explore what others have learned. And we aim to keep it simple and share work happening across the sector at any stage or level of success, not just waiting until the work is completed and ready to be published. We focus primarily on work in South Australia, but every now and then we share a showcase outside of our state to ignite ideas. Quick prompt: if you have a problem or have had success in solving a problem, whether you've learned something trying to do so or you have anything you'd like to see explored in future showcases, please get in touch with us via the email displayed on the screen. We would love to hear if you have a story to tell. And now I'd like to remind you that the theme of our 15th series, which is digital and data-based innovations. We know that innovation and data are interdependent in so many ways, and the landscape is changing rapidly. Each of our speakers has been asked to describe the work they do in this space and to demonstrate how this interdependency exists throughout the innovation journey. And to provide some context to the innovation journey, some of you may already be familiar with the innovation model we released last year that provides an overarching guide to nurturing and maturing a great idea into something that can be purposely developed and deployed at scale. It was constructed from a combination of literature reviews and industry consultation, and is also referenced against the ISO standards for innovation. If you visit our website and have a look, you'll also be able to see that there's useful links and references and guides under each step also. Throughout the series, we've heard from speakers who have shared their insights on the work that they are doing across the sector. As we come to an end of this series, we look forward to hosting the next showcase in September, focusing on clinical variants. As mentioned before, if you do have a story to tell, and in particular to clinical variants for the next sessions, please get in touch. Now it is my pleasure to introduce and welcome today's speakers, Marie Lessing and Craig Martin. Marie is an accomplished digital transformation leader with over 20 years experience spanning clinical practice, ICT strategy, and healthcare innovation. As Director of Digital Transformation for the Rural Support Services, Marie has led the modernisation of regional healthcare services across South Australia. Craig is a strategic healthcare leader with over 20 years' experience spanning public pathology, general practice, pharmaceuticals, and digital health entrepreneurship. As director of CEIH's Link Plus program since January 2025, Craig leads transformative healthcare initiatives, including algorithmic AI-generated discharge summaries to general practice and aged care and remote virtual care monitoring. Thank you to you both.
Thanks, Annie. I'll start us off just saying welcome again to everyone, and we appreciate the opportunity to share our journey on the Regional Care Connect program with people today. The presentation is about how we took existing resources in our regional settings and really just rewired to create an innovative solution for keeping patients healthy and at home after discharge. We'd like to walk you through our collaborative approach, the digital and data elements that made this possible, and the real impact we've seen for patients, clinicians, and the system as a whole. It was really an enjoyable program to be part of. We'd like to start with the provocative question: what if you could reduce hospital readmissions without investing in expensive technology platforms and new systems? And that's exactly what we set out to explore in South Australia's Riverland. Through a collaboration between Renmark Medical Clinic, the local hospital network, Rural Support Service and CEIH, we created what we now call very aptly the Regional Care Connect. We would like to share how we leverage the existing digital tools and data insights to transform care for the patients transitioning from hospital to home. And it isn't just about technology, it is literally about creative problem solving and collaboration. Before we dive into the specifics, I'd like to take a moment to just broaden the context and talk about the unique healthcare landscape in regional South Australia. And of course, many of you will be familiar with the challenges that the regional South Australian population often face in terms of accessing the right healthcare at the right time. We're talking about great distance to essential services and specialists and persistent workforce shortages that often impact the availability and the continuity of care. And of course, the high prevalence of chronic conditions that require consistent and ongoing management. This is often referred to as the tyranny of distance, and a very real and persistent barrier to achieving equitable healthcare outcomes for everyone in our state, regardless of their postcode. Digital and data-driven innovation offer incredible potential as pathways to bridge these gaps, and they bring care closer to home, improve efficiency, and very well demonstrate the empowerment of our patients for their own care. However, and this is the important, crucial part, these innovations must be implemented thoughtfully with a deep understanding of local needs, local context, and local capabilities. And that is precisely what this project, the Regional Care Connect, aimed to do. Over to you, Craig.
Thanks, Marie. Well, to understand our innovation, we first need to understand the challenges we were facing. And in regional areas like the Riverland, patients discharged from hospital, particularly those with chronic conditions, face a high risk of ED readmission. And this is often due to fragmented support and disconnected information flow during that crucial transition period from hospital to home. This challenge can be further compounded by significant pressure on regional GPs, as they often struggle with timely follow-up for these patients, and the scarcity of short notice appointments means patients often can't get the support they need when issues arise. What we were seeing was a lack of digital connectivity between the systems, as well as poor visibility of the patient data across the various care settings, which made coordinated care extremely difficult. What made our approach unique was that we didn't start by purchasing new technologies or platforms. Instead, we took stock of what we already had, our everyday assets that were often underutilised. These included remote monitoring kits that were literally sitting on storeroom shelves, an existing health coaching service that wasn't necessarily being used to its full potential, an underused GP referral portal, a simple risk algorithm, the LACE score, and regular fortnightly team meetings. The key insight for us was that these were all disparate resources, and the innovation wasn't in creating something new, but in connecting these existing elements, often through digital means and data insights, to create a cohesive, proactive care model. And this is a crucial point for healthcare innovation in general. Sometimes the most impactful solutions can come from better utilising what we already have, rather than constantly seeking new technologies. The first step in our Regional Care Connect workflow was identifying which patients would benefit the most from the program. And this is where our data-driven approach came in. We leveraged both GP, general practice, and hospital discharge data to create a more complete picture of each patient's situation. The LACE index, which stands for length of stay, acuity of admission, comorbidities, and emergency department visits, provided us with a simple but effective risk algorithm to better pinpoint vulnerable patients. A key digital component was revitalising the existing GP referral portal, which had been historically underutilised. We then adapted it to streamline communication and referrals for the program. This data-driven identification was crucial because it allowed us to be more proactive rather than reactive. So instead of waiting for patients to deteriorate and present at ED, we could identify those at risk and intervene earlier. And this demonstrated how existing data, when properly utilised and connected, can transform care delivery without requiring new systems. Mari.
Thanks, Greg. Once we identified our at-risk patients through our data-driven approach, the next step was to provide proactive support in their homes. We empowered patients through personalised health coaching, which helped them better understand and manage their conditions. This was complemented by deploying our existing remote patient monitoring kits, which we had an existing management flow, so no new processes, no new funding required, and perhaps better utilisation of what we've got in stock. Regular virtual check-ins and tailored education via this telehealth capability meant that patients did not need to travel for support, particularly important in our regional settings. The digital enablers were crucial. Telehealth and remote monitoring technologies effectively extended our care into our patients' homes. It wasn't about implementing cutting-edge technology, but rather about using existing digital tools more effectively and in a more connected way. And importantly, this approach meant we could detect issues early and address them before requiring emergency intervention. Craig will now take us through the overview of our project journey. Thanks, Craig.
Thanks, Mari. So we've talked about identifying those at-risk patients using the data, and we've touched on about providing proactive support in their homes. So this slide is taking a look at how we stitched it all together. And this slide is meant to serve as a brief overview just before we dive a little deeper into the mechanics. And I think it's important to reiterate that the true innovation of our Regional Care Connect program wasn't about a single shiny new piece of technology. It was about designing a new process, a new way of working that was enabled by intelligently connecting those existing digital and data assets we mentioned earlier. So over the next few slides, we're going to walk you through the key stages of this collaborative workflow, and you'll get to see how data, technology, and most importantly, the people came together to create a more seamless and supportive experience for patients. So let's start at the front end of the Regional Care Connect workflow and how patients were proactively identified and then enrolled into the program. A primary source was the hospital discharge data. Upon discharge, patients who are identified as being at high risk of readmission, often using that LACE index score we discussed, were flagged as potential candidates for the program. We also recognised the crucial role of primary care in this. So the revitalised GP referral portal provided another key pathway. This allowed local GPs to identify and refer suitable patients from within the community, perhaps individuals that the practice knew were struggling with chronic conditions or had a history of frequent hospital visits, who they felt would benefit from the program support. The digital enablers here were twofold: the systematic application of the LACE score calculation to hospital data, and the enhanced functionality and use of the GP referral portal for seamless communication. The overarching focus of this part of the workflow was to be truly proactive. It was about using the data and the digital tools to get ahead of potential crises, to intervene earlier, and to offer support before a patient's condition deteriorated to the point of needing an emergency department visit. Once a patient was enrolled, we moved into the active intervention phase, which was about providing that tailored support and monitoring right in their own home. As we touched on earlier, personalised health coaching delivered by rural support services was a cornerstone. This involved dedicated health coaches working one-on-one with patients, providing education about their conditions, helping them set meaningful self-management goals, and offering consistent encouragement and support. Simultaneously, we deployed remote patient monitoring kits. Patients were equipped with easy-to-use devices to monitor key vital signs daily. For example, their blood pressure, oxygen levels, weight, and sometimes specific symptoms related to their condition. And we found this regular flow of data was absolutely crucial. This monitoring was also complemented by regular virtual check-ins. Using telehealth, our clinical team could conduct follow-up appointments, review the patient's remote patient monitoring data and any reported symptoms, discuss any concerns, and make timely adjustments to their care plans. This provided a responsive and accessible way to manage their care without requiring frequent trips to a clinic. The digital enablers here were, of course, the remote patient monitoring devices themselves and the telehealth platforms that facilitated these virtual connections. The focus of this phase was clear. We wanted to extend effective, personalised and continuous care directly into the patient's home environment, additionally empowering them to take an active role in their own health. The final part of the workflow focuses on the back end, the ongoing management, collaboration, and crucially, timely escalation when needed. A dedicated monitoring team, often the nurses from the rural support services, played a key role in daily data review and any associated triage. They would review the incoming remote patient monitoring data and any patient-reported symptoms each day, looking for trends, anomalies, or any red flags that might indicate a patient's condition was changing. This individual monitoring was then complemented by the power of collaborative discussion. There were fortnightly cross-sector meetings that we mentioned earlier, and they became a vital forum. Here, general practitioners, their practice staff, hospital staff, and the RSS team could come together to discuss enrolled patients, review those patients' progress, share insights, and collaboratively adjust associated care plans. This ensured everyone was on the same page. And critically, we established clear escalation pathways. There were agreed upon protocols for what to do if a patient's data or symptoms raised concerns, and this ensured that issues could be escalated appropriately and, most importantly, in a timely manner, whether that was to the patient's GP for a review or, in more urgent cases, back to the hospital. The digital enablers here included shared data views, even if they are relatively simple dashboards or reports initially, and secure communication channels that allowed the different parts of the care team to connect efficiently. The focus of this final phase was all about ensuring a truly connected care team and fostering a system of rapid response to prevent patient deterioration and avoid any unnecessary hospital visits.
Thanks, Craig. If we can now talk about how we made this happen and really the practical steps in our innovation journey. First off, the essential deep need finding that we all contributed to. We spent quite a bit of time at the start of the program to truly understand the pain points of patients, carers, and clinicians. And this wasn't about just the surface level issues that we all knew about. It was literally digging into root causes of readmissions and care gaps. The rapid co-design cycles that brought all partners to the table, including the clinic, rural support services, and CEIH. And I think it's really important to note that everybody was invested. It was a true partnership, and there wasn't a single leader to the program. Everybody was invested in achieving this. This collaborative approach ensured that the solution addressed needs across the care continuum. And this cross-section collaboration that was basically the recipe to the success was probably also the most challenging, but obviously very rewarding aspect of the program. We had to break down traditional silos between hospital and primary care and between clinicians and technologists. The critical element was using the CEIH innovation model as a safety check and guardrails throughout our process. This evidence-based stage approach helped us to validate that we were following best practice as we moved from ideation to implementation. And as we saw before, that the 4 stages of the model, the ideation and collaboration, design and development, produce and propel, scale and sustain, provided this structured framework that was really beneficial in helping us to make it happen. It ensured that we weren't missing critical steps in our innovation journey. And finally, iteration and learning were built into our approach. We continuously developed our digital tools and processes based on real-world feedback. And they weren't earth-shattering revelations. We were all senior, experienced participants. But it was the small changes that we could do in a rapid way that basically supported the progress of this project. One example is the referral portal that underwent several iterations to make it more user-friendly for business clinicians. And we believe these steps are repeatable and can serve as a template for some similar innovation elsewhere, basically a lift and shift approach. If we look at the impact of Regional Care Connect, starting with the quantitative outcomes, and this is the slide that I enjoy most presenting, we've seen an 80% reduction in ED visits for patients enrolled in the program. This is significant, not just for our patients' well-being, but also for system efficiency. We've been able to prevent hospital admissions that would otherwise have occurred without this proactive approach. From a patient perspective, we've achieved 100% patient-reported confidence and safety in managing their own health at home. crucial outcome for a program that aims to keep people out of the hospital. From an efficiency standpoint, we have reduced administration time by 3 to 4 hours a week for the clinical teams, allowing them to focus more on direct patient care. These results demonstrate that by better connecting existing resources through digital means and data insights, we can achieve significant improvements in both patient outcomes and system efficiency. We will just do a really short video testimony from one of our patients just to prove that we have actually done this efficiently and patients are noticing the outcome of this program.
Before I started home monitoring, I attended emergency department 7 times in 1 year, 5 times by ambulance. Since finishing the program 1 year ago, I have not been back to hospital. The VCC nurses helped me to learn about my heart condition and sent results to my cardiologist. My medications were changed. When I was having symptoms, it was a very frightening experience. The nurses were able to reassure and relieve my anxiety using my action plan. They referred me to cardiac rehab, and my health has improved significantly.
Beyond the numbers, we also wanted to share some direct feedback from the lead GP and their general practice support team at the participating practice, which we think provides some valuable insights into the program's impact. They highlighted how the program increased patient sense of security, particularly valuable in a region where getting GP appointments at short notice is quite challenging. Regular contact from the monitoring team and the knowledge that issues would be escalated to the GP provided quite a high level and peace of mind for both the patients and the practitioners. From the GP's perspective, a significant benefit was the reduced burden of routine follow-up. In their words, this assists when we are so time poor, which allowed them to focus on urgent cases while seeing stable patients less frequently but more effectively. The program also delivered direct benefits to patients through reduced costs and valuable education on using monitoring equipment. And this feedback reinforced to us that our digital and data-enabled approach not only improved patient care, but also supported more efficient and effective general practice.
Thanks, Craig. Drawing from our experience with Regional Care Connect, we've identified several key learnings about weaving digital and data capabilities into collaborative care models. First of all, collaboration truly is paramount. And I think we were lucky with really engaged stakeholders and partners, which made this program it was a joy to be part of this. Integrated pathways supported by shared data are far more effective than siloed approaches. The digital connections between hospital, GP and support services were essential enablers for this collaboration. We learned the power of leveraging existing assets creatively. Rewiring with digital connections can be more impactful and sustainable than implementing entire new systems. And of course, the turnaround is a lot quicker when everybody is familiar with the parts of the process. Thirdly, the data-driven insights prove crucial for proactive targeted care. Without the risk stratification and regular monitoring data, we would have remained in reactive mode. Digital tools like telehealth portals and monitoring systems were key enablers for access, efficiency, and patient empowerment, particularly important in our regional settings. And finally, the user-centric design and iteration were vital for successful technology adoption. both patients and clinicians needed to find the digital components intuitive and valuable for the program to succeed. Thanks, Craig.
Thanks, Mari. On this slide, I'd like to share with you the three biggest hurdles we encountered and the approaches we then used to move past them. Challenge one, when we introduced the remote monitoring kits, some patients and clinicians were naturally cautious. So we kept the technology experience as close to plug and play as possible and paired them with brief practical coaching. And we found that within days, confidence levels were high and accurate readings from the kits through to the monitoring teams were flowing quite well. The second challenge, our hospital, GP and monitoring data lived in separate systems, which unfortunately in healthcare today is an all too common problem. So rather than waiting for a major IT overhaul, we agreed on the minimum data needed for safe care and routed it through tools we already owned. This then gave clinicians the essential information in real time without new procurement. And the third challenge we found was initial enthusiasm can fade if people don't see ongoing value. So we schedule short, regular touch points to share quick wins and patient stories, keeping leadership visible and momentum high. And 6 months in, participation and satisfaction remains strong. And if anything, from my perspective, it actually continued to grow. So taken together, we found these focused, proportionate actions showed us that meaningful progress is possible, and even with modest resources, by targeting the real pain points and connecting what we already have. So looking forward, we believe the Regional Care Connect model demonstrates significant potential for broader application across South Australia. The key success factors we've identified, deep need finding, co-design, collaboration, and the smart use of technology are repeatable and can be applied in other contexts and regions. I'm also excited to share that we now have work underway to publish the results of this pilot in peer-reviewed literature. Our comprehensive literature review has already confirmed that our integrated approach, combining the remote monitoring, risk stratification using the LACE score, rural integrated care, health literacy support, and patient experience outcomes fills an important gap in the current evidence base. In the medium term, we're planning to apply for funding through the Medical Research Future Fund, the National Health and Medical Research Council, or other suitable grants to support further research and scaling of this model. And this will help us gather more robust evidence on long-term outcomes, as well as the cost effectiveness, which will inform future deployment across the state. We also want to emphasize the crucial role of digital and data strategies in enabling scalable, equitable, and efficient healthcare. As we look to transform healthcare delivery across South Australia, these capabilities will be essential foundations. And we believe the Regional Care Connect journey shows that meaningful innovation doesn't always require new platforms or significant investments. Sometimes it's about connecting what we already have in smarter ways and then building the evidence base to support wider adoption.
This brings us to the end of the presentation, and on behalf of Craig and myself, thank you very much for your time and attention today. We hope we've given you a valuable insight into the Regional Care Connect initiative. For those who are interested in digging deeper into the program details, you can find more information by searching for Regional Care Connect on the SA Health website. And we would now be delighted to answer any questions you may have. Thanks.